I think we're ready to get started. Thanks for joining us for our grand rounds, but we do have a resident warm-up this morning to start us off. So Chief Such, would you like to introduce our warm-up speaker?
Dr. Schenk, are you ready to get started?
Oh, yep.
Wonderful.
To get started. So would you like to introduce our warm-up
Sure.
speaker?
Yep. All right. Well, welcome to our grand rounds today. We're excited to have the State of the Children's Center. But before we do, we're also excited that we're going to be doing our first grand round warm-up today. We have one of our second years, John Hammond, who hails from Michigan. He went to Brown for undergrad and for medical school and is interested in hematology oncology. Before he actually went to medical school though, he was a research coordinator for a number of studies at CHOP, which he's going to be discussing today. And he also was part of the EPIC team and did a lot of implementation. So has had a very interesting path here. And we're excited to hear about his grand round warm-ups topic today. And these are just the CME slides. And then,
hi everyone. Today's topic is an update on gene therapy and hemoglobinopathies. I have no relevant financial disclosures. We will be discussing unapproved drug products during today's talk, which are currently in clinical trials. And here are the learning objectives for today. So to provide a little bit of background, the beta hemoglobinopathies include beta thalassemia and sickle cell disease, and are among the most common single gene disorders across the world. In their most severe clinical forms, both beta thalassemia and sickle cell disease are associated with significant morbidity and mortality. And in their most severe clinical forms may require chronic red blood cell transfusions with all of the morbidity that entails. At the current time, the only curative therapy is allogeneic stem cell transplant, which requires a donor, typically a matched sibling, and comes with a risk of graft versus host disease. The promise of gene therapy, which in this context refers to autologous stem cell transplant, is that it presents the possibility of a cure, doesn't require a donor, and doesn't come with any risk of graft versus host disease. So what do I mean when I say gene therapy? What do these clinical trials involve? We're going to look at a few of the studies in more detail, but just to provide a broader study comparison. Similarities is that they're all single arm. There are no placebo arms in these studies. The inclusion criteria generally include either transfusion-dependent beta thalassemia, so transfusion-dependent meaning greater than 10 units of red blood cells per year, typically, or severe sickle cell disease. Severe meaning typically defined based on the rate of complications, so rate of pain crises, rate of acute chest syndrome. Exclusion criteria, there are many, but just to point out a couple of the important ones, these patients can have had a prior stem cell transplant, and in some cases, they can't have a known matched donor. The protocol for these studies, for all these studies, is also broadly fairly similar in structure. So the first step is generally mobilization of CD34 positive hematopoietic stem cells. This is done using drugs like plerixafor or GCSF, although GCSF is contraindicated in sickle cell disease. After these drugs are given, the cells are collected via apheresis and sent to an outside facility where they're manipulated. The patients then undergo myeloablative conditioning with busulfan. The cells are sent back to the hospital and they're infused into the peripheral blood of the patient. Where the differences really arise in these studies is in that cell manipulation phase. So the molecular target for these studies is often different. Some of these studies involve either gamma or beta globin addition into the genome. Other of these studies look to inhibit BCL11A. BCL11A is a gene that essentially functions as a fetal hemoglobin on-off switch. By inhibiting it, you can induce fetal hemoglobin production. The mechanisms by which these targets are affected are also different. Some of these studies use a lentiviral vector to add that gene into the genome. Others use CRISPR-Cas9 technology. CRISPR-Cas9 uses an RNA guide and then an enzyme that can induce breaks in DNA, double-stranded breaks in DNA, to really specifically edit the genome. All right, so to look at a few studies in more detail, the studies that we're gonna look at most closely are the Bluebird Bio studies, both a set in thalassemia and a study in sickle cell. And the reason we're looking at these is just because these studies have been enrolling patients for the longest and have released the most data. The protocol HCB-204-205 is a phase 1, phase 2 study. Data was initially released in April of 2018. This study is in patients with transfusion-dependent beta thalassemia and uses a lentiviral vector to add a functional beta globin gene. The results from this study were overall very encouraging. From a safety perspective, there were 9 serious adverse events, none of which were found to be related to the drug product. There were 2 episodes of veno-occlusive disease found to be secondary to busulfan conditioning. And overall, the effects were found to be consistent with stem cell transplant. There's no evidence of clonal dominance, so no evidence of malignancy associated with the drug product or the site in the genome where the drug product was inserted. And there was no evidence of that lentiviral vector being activated into active virus. The results as well were very encouraging. So at a mean of 26 months, 12 of 13 patients with non-beta 0 genotypes were no longer needing blood transfusions, and 3 of 9 with beta 0 genotypes were no longer needing blood transfusions with a significantly decreased annualized transfusion volume. These patients from the 204 study have continued to be followed after that initial data release. And the results have shown that these patients are generally able to sustain that transfusion independence. So at the most recent data cut, those patients who had achieved transfusion independence had sustained that independence for about 40 months. Phase 3 studies are also open using similar technology in a similar group of patients. That's HCB-207 and 212. 9 of 10 patients in HCB-207 no longer needing blood transfusions, and 9 of 11 in HCB-212 no longer needing blood transfusions, with an overall similar safety profile to previous studies. HCB-206 is also a Bluebird style. It's a Bluebird Bio study. It's phase 1, phase 2. Also adds a beta globin using a lentiviral vector in patients with severe sickle cell disease. And in particular, this study, the data I'm going to talk about is from Group C, which is a group of patients that were enrolled after the mobilization process was optimized. They tried to collect the CD34 cells with bone marrow harvest initially, but were unsuccessful. And so opted for that plerixafor and apheresis process. Again, the safety profile consistent with the known effects of stem cell transplant. 1 patient did develop myelodysplastic syndrome 36 months after infusion. This was deemed unrelated to the drug product and again related to busulfan conditioning. The results are listed here. 17 of 17 patients were able to discontinue red blood cell transfusions by 90 days out from that drug product infusion. And as we'll see on this next slide, there was really a pretty drastic reduction in the rate of sickle cell complications. So that line in the center represents the time point of drug product infusion. To the left, each of those individual diamonds represents either a pain crisis or an episode of acute chest pre-infusion. And to the right, we can see that after infusion of this drug product, there was 1 single pain crisis in 1 single patient. We don't have time to talk about additional ongoing studies, but there are several in various stages of development. Cincinnati has a protocol in patients with severe sickle cell disease that adds a gamma globin, functional gamma globin with a lentiviral vector. Boston has a protocol that uses a lentiviral vector to encode an RNA inhibitor that targets that fetal hemoglobin on-off switch in patients with severe sickle cell disease. And Vertex Pharmaceuticals has a CRISPR-Cas9 study that again targets that BCL11A gene in patients with thalassemia or severe sickle cell disease. Of note, this is the first scientific report of patients with a human genetic disease treated successfully with CRISPR. Again, data from only a handful of patients has been released for any of these studies, but so far the safety profile has proven to be consistent with the known effects of stem cell transplant, and the data regarding transfusion independence has been similarly promising. So where do we go from here? What's next? Obviously, none of these products are approved by the FDA at this time. We need to continue to collect and evaluate efficacy and safety data from all of these trials. Of note, the Bluebird Bio product has been conditionally approved in Europe as of summer 2019. We need to think about an economic model for all of these interventions. So these are gene therapies and an intervention that will require significant and steep upfront costs, but could potentially result in pretty significant long-term savings as well. Who will bear the brunt of these costs? Who will get to see these savings? And this is something that insurance companies will pay for. And finally, accessibility. Who will get access to gene therapy if it does pan out? And who will decide who gets that access? So my take-home points. While current protocols are similar in overall process, there are significant differences in mechanism and target of cell manipulation. Early safety and efficacy data have been encouraging, but we need additional data. There remains much uncertainty as to future implementation and economic models that will support gene therapy. Thank you for your time. Here are my references.
Thank you so much, John. That was great. All right. So hope people can see this. We are moving into the state of Johns Hopkins Children's Center and the Department of Pediatrics. And thank you for joining us today. This is the beginning of our new academic year, and we always start out with really talking about where we're at in the Children's Center. So I'm going to turn it over to Maggie.
Thank you, Tina. I think you're running the slides though.
Yep.
So thanks everybody and welcome to this State of the Children's Center. Go ahead into the next slide. Who's running the slides?
I turned them, I can see them, but you can't see them, huh?
I can see them, I just can't forward them.
Yeah, no, I forwarded it to the next slides, but I guess you're not seeing them.
And restart.
Do you see them now?
I can, yeah, good. But,
I think presenter mode doesn't work.
okay. Back up one. Okay, so I just wanted to open with just a review of the mission and vision of the Children's Center. We're an impressive place, and I think our mission and our vision, as you guys can see on the screen, is really something that guides us. So let's keep going, and we'll have an interesting conversation about where that has taken us today and where we're going to go next. So we're going to talk about where we've been this past year, and there's lots of highlights and lots of lowlights too. It's been a tough year. And then Dr. David Hackham is going to help us present the status reports for the Children's Center. And I'm very happy to spend some time listening to Dr. Chang talk about her experiences and her reflections and what she sees as the accomplishments of the Children's Center as she steps on to another even more exciting spot. And then I'm going to come back and we'll talk about what's going to happen, our objectives for the year going forward. Next. So it has been a fascinating year. A year maybe some of us would be happy enough just to get away from, but it's still here with us. We've got a lot going on, and I think we've been focused a lot on the challenges, and COVID is probably at the top list of our challenge. And in addition to that, the incredible frustrations of injustice and concerns about equity, the financial pressures that we have been visited upon us by the institution and in our experience with COVID, they've all really added to the stress and the difficulties of this year. But at the same time, and I think Tina's really going to focus on this, we have a lot of things to be incredibly proud of and a lot of very bright spots in what has been a difficult year. So I look forward to a little conversation about that. Next. But to focus on COVID, I just included here just a list of some of the things that we have experienced with COVID, the whole notion of pandemic planning and how much attention that took from all of us, right? A lot of creativity, a lot of attention drawn away from the work that we normally do and the concerns that we normally have. So pandemic planning, concerns about protective equipment, preservations, the difficulties of physical distancing and how much that impacted not just our care of patients and our relationships with families, but also our relationships with each other. It's funny, you wear a mask all day and it's hard to know if somebody's smiling at you and trying to say hello. I think we're all getting very good at reading each other's eyes. But it's been a very odd time and very difficult time. I think in the sort of the arena of all of that is this issue that, we believe in science, and COVID has really been an experience of science clashing with politics and culture in a way that's been fascinating but disconcerting. So let's keep going. I want to talk for a second about how the Children's Center responded to the COVID crisis. And this is just a short list, and the list could be 3 times as long, about all the cool things that we did. Our Incident Command Center opened up and was powerful, and I think it helped us stay coordinated. The PICU did this incredible work about flipping for adults, really setting a bar and showing the hospital and our system what nimble thinking and creative work can look like. We did have a lot of people who helped us with outward-facing communications to help educate our community. Our ambulatory team really led a lot of the thinking in the hospital about ramping up and ramping down and how to conduct safe care in the ambulatory setting. From the research side, the Bead Corps worked really quickly to come up with the COVID rapid response consults for people who are interested in research around COVID. PICU, several members of our PICU led sort of the MISC collaborative that helped a lot with the way we were caring for these super complicated pediatric patients. So it actually was a really interesting experience. And I think what it taught me is that we as a Children's Center are ready to think this way again. So go ahead, Tina, the next one. So we're wondering right now, I'm sorry, before I go on, I love this slide. I think Tina, this is one of Tina's favorites, and it's so funny. I mean, not only did we flip the PICU for some adult patients, we deployed our experts all over the hospital. And I love this, that we taught them a little bit about pediatric language and managing adult patients. So proning turned into tummy time. And I think that was really wonderful. But go on, Tina. But what I was getting to is that our experience in the Children's Center has given me the confidence that should we get bad with COVID again, we know how to respond. It will look different this time because of COVID. If we do have another surge, it's going to be in addition to flu season, a respiratory virus season, which makes it 3 times scarier. But we did a pretty good job with thinking quickly and communicating effectively. So I feel confident that we can do it again. But is there more to come? So this is, we're always watching the models, who's saying what about what's happening next with COVID. And I like this from the CDC. You can see that all the different modeling models that exist right now, and they don't really align particularly well. Even the 2 from Hopkins don't align very well. So I think the point here is that we have reason to worry, but we don't actually know what's coming next. But let's look at the next slide. This is the one that I think actually matters a lot to us. This is Hopkins data. So the slide, the top one shows you the number of patients, the cases, actually the number of COVID patients admitted to the hospital over the last several months. And you can see the trend is very sharply down, very consistently down, except at the very, very end. But look at the other slide. The darkest line near the bottom, the dark is the pediatric, the cases under the age of 20. So on the left, it's numbers of cases. On the right, it's percentage of patients. And it is concerning. We should all be concerned that on both of these, there's a blip upwards for the pediatric cases. So I think that we are have reasons to be concerned, have reasons to be very thoughtful about the planning going forward. The good news is we are making those plans going forward, and we are working with a hospital and trying to come up with the most effective responses. So let's keep going though. In addition to sort of the day-to-day care of patients and bed planning and all the craziness, a lot of people took time out to think more broadly about the impact of COVID on pediatric patients, on children, not just patients, but children in the community, children in society. So here's a couple of articles. One Tina and I worked on together about the safety net for children in the COVID pandemic. Another one published, Megan Schutte was one of the authors, published in JAMA Pediatrics, about the specific effects of coronavirus on low-income children. The point being that children didn't get all that sick from COVID for the most part, but they are hugely affected by the experience of coronavirus in the US and throughout the world. So it's something important for us to continue to think about. Next one. And then in addition to sort of the concerns about economics and children, this really, the AAP has worked very hard to sort of bring this issue about how important it is for children to get back to school. That is as you all know, and especially those of you with young children, school-age children know, this is a remarkably complicated issue. So I think that Hopkins has also led the way in thinking about the initiatives and what resources we need to help schools with to make planning for a safe and equitable return to school. Next. So on top of the COVID epidemic, the racial and social injustice pandemic has been incredibly disturbing. I think, it's not new news that we are an unjust culture, but with the killing of George Floyd, it really helped us to start again, to think, where have we gone wrong? What do we need to do? What is the work necessary to make this a better place, a more just place? And I think it is something that has been a huge concern to many, many people in the Children's Center. And I admire, go ahead to the next one, some of the work being done in the Children's Center to help us have a conversation, help us understand each other, help us to make plans moving forward to make equity something that we can really point to, that's something that we are good at, and to work against bias, against discrimination, and see if we can make a difference, at least in our communities and our hospital. So these are some of the Department of Pediatrics Grand Rounds and the Focus on Health Equity series. And I think we have Tina really to thank for pushing hard to get this well organized. So I hope you guys had a chance to go to the ones in August about implicit bias and the innovations. And coming up in October, we'll have more with Errol Fields talking about impact on special populations. We'll talk a little bit more about the Charm City documentary, and then again in November, we'll have another one. So keep going. So I think Keith Kleiman gets some kudos for sort of leading the way about this Charm City documentary. I hope many of you have seen this already, but in October, we'll have a chance to watch this wonderful movie as a group, to really think it's going to be a wonderful sort of public viewing. Again, everybody in their own home or on their own computers or own TVs, but we'll get to view this movie together and then use our Grand Rounds time to have a panel discussion with several people from the movie itself, including Brandon Scott, who is a candidate for Baltimore City Mayor. So it's going to be a wonderful experience. And I think this is one of those things that will help us share an understanding of our community in a way that I think will be really positive. All right, let's keep going. So I'm going to stop here and turn it over to David Hackland, who's going to review with us some of the updates of what's been going on this year.
Yeah, thanks everyone. Hello, it's great to be with you this afternoon. There's 242 of you, but I know there's thousands more logging in from around the world. They just aren't being counted. This is a highlight of the academic year, of our clinical year. We love standing in front of you as a leadership team and sharing the progress. This year, as Dr. Moon mentioned, there's a lot to be proud of, but also a lot to be really scared about. And that story continues. Just on Friday, we had a 14-year-old boy who was shot multiple times in his chest and died literally in the arms of the trauma team. And as sad and as horrific as that event was, an event that should never, ever occur, it brought out the best in the teams that were mobilized to take care of this child and his family. And also knowing that behind the scenes are so many great initiatives, as Maggie and Tina have mentioned, to prevent the violence in the communities, to bring the resources to bear, and really to extend a conversation that has begun nationally but affects each of us locally. And I couldn't be proud of our teams, but also struck by how urgent the need is to solve these problems. Turning to the presentation, Johns Hopkins extends its reach and its ability to take care of kids throughout the community, throughout the region, and that is really shown on this slide. And you can see the number of sites that we provide care. In the next slide, please. You can see also that we provide that care not just as a Department of Pediatrics, which is an incredible department, which I'm proud to work alongside. And you can see the 15 divisions that are highlighted there, some of which are in the throes of leadership searches, shown in red. And also huge congratulations to Dr. Maria Trent, shown in green on her recent appointments and endowed chair, really proud. But in the next slide, you can see also, I think the next slide, you can also see that the Children's Center is more than the Department of Pediatrics. I would never say just the Department of Pediatrics. It's more than the Department of Pediatrics. It's an equal number of divisions outside of the department. And that's why we have the leadership structure that we have, which is a co-directorship where the voice of all those that are proud to serve at the Children's Center are at the table and are included in conversations that affect each of us and allow us to take care of kids. In the next slide, you can see that we take care of kids not at the Johns Hopkins Children's Center alone and not at those extended sites, but now also, and every time this slide is shown, people are surprised to see it, but we extend pediatric surgical care from central Pennsylvania all the way down to the National Capital Region. And so our surgeons will travel to York, will travel to Anne Arundel, to Annapolis, will travel to Rockville, Maryland, and of course, Howard County and GBMC. And this is just our commitment to take care of kids in the region. We believe that community pediatric surgery should largely be performed in the community. And for those kids that need extended quaternary tertiary care, we believe Johns Hopkins Children's Center is their destination of choice. This is just pediatric surgery, but pediatric cardiology, pediatric endocrinology, et cetera, has the same approach, which is really a transformation of care in the region and fulfills all of our tripartite mission by extending training opportunities and research opportunities. In the next slide, and there's our newest member of the family. This is a fairly detailed slide, but it basically just underscores what I shared, that we are, in a sense, spread out really thin. I mean, compared to freestanding children's hospitals, there's relatively few of us, and yet we are committed to providing this care in each of these sites. And it also demands that we have a structure in place so that we're providing excellence at each of these sites. This is a good opportunity to call out our Pediatrics at Home, Sue Huff and her colleagues for the tremendous work that they do, not just in Baltimore, but really throughout Maryland and the National Capital Region. And to our tremendous transport teams under combined leadership of many of you who are on this call, for the hard work that they do to make sure that any kid that needs our care can be brought here as quickly and safely as possible. We couldn't be prouder for the work that is reflected on this slide. The next slide shows a little bit of the finances, and for that I'm going to turn to a financier, and I think Mark is standing by ready to share some thoughts. So in turning it over, just in brief closing on this part, the Johns Hopkins Children's Center stands for excellence, it stands for commitment, it stands for partnership, and I use the example of the death in the trauma bay as an example of the worst of situations that brings out the best in us. But we extend that care into so many places, and that care really reflects the teamwork from all of those that are affiliated with the Children's Center. Mark, over to you.
Yeah, I think you may, Tina, just want to flash the surgical volumes and the outpatient volumes that maybe are next in the slide deck. You can see at a high level, David may want to comment further on that.
I mean, I think there are people and various subspecialists that are on the call, and their hard work is reflected here in the volumes. And this is despite COVID. So whereas the adult side of the operation largely ground to a halt, and certainly our elective practices did, we did not stop taking care of newborns with surgical emergencies, critically injured children, burned children, etc. And so our volumes were relatively stable compared to what it might have been, considering that all elective work was stopped. And really, you see here urology, plastics, etc., contributing to our mission. In the next slide, just as Mark said, I think you'll see here some pre and post-COVID work, doing our best to maintain the work that everyone knows how hard you're working. We acknowledge that, we respect that, and we're here to make it even easier to get back to pre-COVID volumes. And in the next slide, I'll turn this over to Mark. Thank you.
Thank you, David. So again, I want to add my thanks to your tenacity regarding the journey to remain available and open for business for the patients and families we serve, notwithstanding the public health and the financial crisis around COVID. And so your tenacity and your success around that, your achievements, have dumped into the financial performance. And so the good news is, notwithstanding all of these challenges, we performed fairly well, notwithstanding the COVID financial experience that many other institutions have experienced. So from a children's center perspective, we were almost $1 million better than budget. A lot of that was around expense management, but the important side of this is you kept us available and open for business for those kiddos, those patients and families that need us, and it was reflected in the financial performance for the Children's Center. And of course, throughout the department, as you worked hard to effectuate the ambulatory clinical ramp up and keep research going and manage your expenses carefully and suffer the pain of some of our workforce management, which is some of our major expense, it all equated to, a $3+ million surplus relative to the bottom line. So Pediatrics did exceedingly well. Some might argue because the COVID experience is less severe than the adult side, but nonetheless, we had our experiences, we had our severities, we did our part in the bigger effort, we had our financial challenges, and we rose to the occasion and stood up to the task, and you have this financial performance to be proud of. Now, underneath that, there are some one-timers, some gifts, some 340B money, things of that nature that, I'll say, put a nice veil over operating performance, how we do in our core business, both the clinical activity and the research side when we're looking at revenue versus expenses. I don't want to sound too financial, but these things are pluses. But as a baseline, we try to make sure that we're as financially solid and strong as we can be in our core businesses and our missions. So good news so far. I would flash that for the first year of 21, so July basically, we are meeting our budget indicators, which shows really strong effort carrying into the new fiscal year. As you've heard in other forums, perhaps, we have a right-sized budget for 21 on both the School of Medicine and the hospital side. That factors in that there's going to be more clinical ramp up to get to full strength regarding COVID and other things. And so the budget assumption right now is come October 1, we will be back to full clinical activity. So that's a journey. So far, we're roughly, in call it order of magnitude, about 80% of the way there. There are some variations to that. So great performance so far, more to go before we finish. I'll keep going in the interest of time. We had to do every year, like this year, like every year, a number of performance improvement plans. The good news is we performed well against those. There's a lot of clinical activity that we do through which, our paperwork, our documentation, our coding, things like that are not up to, speed, so to speak, where they need to be. And so we don't get to charge that and get paid for what we do. So this work is critically important to swing back around, get that documentation right, and get paid for what we do under the GBR. This is basically highlighting that we had $2 million worth of gain in that regard. Kudos to that team. And then venues of care, as we pursue population health, we're aggressively trying to move a number of things from a more expensive, either inpatient environment or a regulated outpatient environment to either unregulated space or less expensive entities like Peds at Home. And so we've been able to do that, for example, in our infusion activity, and you'll see more of that occur. So kudos to those folks. And just to kind of round this out, I'll say a couple of things, notwithstanding all these budget challenges, we were able to advance a number of important business proposals, right? New programming, advanced programming, things that keep our mission strong and robust and keep our Children's Center and Pediatrics moving forward. The Heart Center is in full throes. We were able to really create a more comprehensive palliative care program. We have worked with Child Psych on a more extensive program there. We have ED sedation that's been approved and is in the hopper to operationalize at the right time as volumes increase. We're putting the final touches on an offer for Ped Urology Division Director and the business planning around that so many people have worked on. And you can go from there. And so there's lots of good stuff, and there will be more good stuff going forward. So I want to thank all of our partners there who helped us make those things a reality. And then budgeting, which is always such a nightmare in terms of its time intensity and its layering, given how complicated of an organization we are. Good news is, from Rob Kasdan down, from the very top of JHM, we're working on an integrated budget process starting in fiscal year 22 that at a high level does a whole lot of integration among the entities regarding budget creation, consolidation, simplification, coordination of both forecasting clinical activity, budgeting them properly, budgeting the labor side and the supply side of that so that we have some coordination and synchronization to what we're doing, let's say on the pro-fee side and the hospital side. So lots of good stuff there. And then EPSI is just an automated tool that helps us track and monitor all of that. So a lot in there. I don't mean to do too much corporate speak, but wanted to make sure you had this side of it. Happy to answer any further questions.
Great. So I'll go ahead and continue on a little bit. I think, thank you, Mark, for that. And I think it's always easy to be terrified about our financial situation. It's great to hear that we've done a great job. And I think we'll continue to do that going forward with your help and under your leadership. I want to thank our development team. So the Radiothon raised $1.43 million. And I think that's incredibly cool. I really admire the work that you guys do to get that set up. Tina's going to talk about the Endowed Professorships, and I think we can also celebrate Baltimore Boogie and Team Hopkins. This is the dollars raised by Philanthropy, so we'll hear a little bit more about the professorships as we mentioned, but strong support still from the Udawood and Harriet Lane and Garrett boards. I appreciate very much the work of Allison Baker and her team in terms of pushing development and getting the continued philanthropy. It makes such a difference to the work we're doing. From the marketing side, Shannon Shikante has been our contact with marketing for the last year, and you can see the good work that they've done. They really responded in the COVID epidemic. A lot of outward-facing work done there. In addition to that, I think the next slide is helpful also, Tina. Yeah, so the COVID-specific outreach, over 1 million page views to our COVID-19 pages. I think Hopkins, overall, from the School of Public Health to the School of Medicine, has really been on the forefront of a lot of the COVID stuff. So we have valued marketing and sort of making sure that we're getting recognized that way. And let's keep going. All right, so at this time, I am very happy to hand this over to Tina Cheng, because I think Tina has some ideas to share, some thoughts to share with us as she's thinking about her experience at Hopkins. So thank you, Tina.
Sure. So, I was asked to talk a little bit about some of the accomplishments over the last 4.5 years that I've been in this position, and some of the ideas on looking towards the future. So in talking about accomplishments, it's always a little dangerous that you're going to leave something out, and I'm sure I will leave something out, but I think we have a lot to be proud of. I think it starts with our people. And I think we all know that what makes Hopkins amazing is our people. And there's been many areas where we've had accomplishment in this area. I think one area that I've really tried to work on is really making sure that we in the pediatric community really feel like a community and work well as a team. And we all know that it takes a village to really address the needs of children and families and meet our tripartite mission. And I can't be more thankful for all the people that are part of that team and work so hard every day for the sake of our patients. That's from nursing to social work to child life to the Patient and Family Advisory Council to all the, to EBS, to everybody that makes us able to function. And I think we've had a lot of great initiatives in this area, including our town halls, including our resilience initiative of bringing people together to talk about how we can be resilient as providers, but also how we can really help our patients. And communication, I think, is key, and it's been fun to communicate through the Pediatric Pulse. I think we've done a great job as far as building the infrastructure for the Children's Center and recruitments and promotions for the Department of Pediatrics and the other departments that are focused on children. We've had success in professorships, and we've had a couple of new divisions, hospital medicine and adolescent and young adult medicine. I think a long time coming, but I think really makes sense to make sure that we provide the best care. So just looking at this is just the leadership recruitments from the Children's Center and the Department of Pediatrics over the last 4.5 years. And there's been some turnover, which there always is, but also we've been able to build some new infrastructure. And some of the red font is really the new infrastructure that we've been able to build, like a chief medical officer, like a chief informatics officer, like the development of a heart center that is really building, and including cardiac ICU. So really a lot of leadership recruitment and a lot of infrastructure that has been built that I think will serve the Children's Center for decades to come. The new endowed professorships, 6 of them in 1 year is pretty incredible. It does take time to develop these endowments for professorships, and you know, each philanthropist has some say, obviously, and where they would like to invest their money, but really feel like it's great to be able to recognize some of our outstanding faculty in new professorships this year. And I think that there may be some more to come as well before I leave. As far as education, we've always had really strong medical student, resident, fellowship training, and child health professional training. I mean, there's so many nurse trainees, child life trainees, etc. That is really important for the future of child health. We've had a new residency program tracks, the accelerated research pathway to really try to strengthen our pipeline for research, a new program track in health equity and global health, and of course our Harriet Lane Handbook. And we all know that as every pediatrician has a Harriet Lane Handbook and can mark their time by the color of the handbook. Mine was gray, that you don't even see on the shelf because it was a much earlier edition. But it's pretty amazing that we've been able to put out 22 editions of the Harriet Lane Handbook, and it continues to be such an important resource for pediatrics around the world. And thank our residents for editing and putting the book together. But 22nd editions, these first editions started before I was born. So really incredible legacy. And of course, research, lots of research accomplishments. We've had growth in research funding during really tough financial times, which is amazing. We've been able to be around.
Something's going wrong with your mic. It's super fuzzy all of a sudden.
Okay.
There, that's better.
We've been able to give out innovation grants for clinical education and research, over $500,000 a year. A lot of that coming from the philanthropy we have received. Of course, it should be noted that Greg Semenza, who is a pediatrician, received the Nobel Prize in 2019, which is tremendous. And he was in the Department of Pediatrics for many years, until 4 months before he got the Nobel Prize. The Department of Genetics became a department, but we still claim him as part of the Children's Center, and the incredible recognition that the Nobel Prize has given him. And then really proud of the fact that we have 2 precision medicine centers of excellence involving children, with Hal Dietz, as well as Francis Northington in neonatology. And I think that these precision medicine centers of excellence, through their use also of the PMAT computing platform, will be able to really further our work in precision medicine and really focus on early antecedents of adult disease. And then of course, clinical care, lots in clinical care, increased beds in our NICU. We've opened an epilepsy monitoring unit. The cardiac ICU is now being formed. In addition to our regular PICU, we have the new Pediatric Heart Center. That's a real first for us, that bring together the departments of pediatrics, anesthesia, and critical care medicine and surgery to a governance structure that involves the Children's Center as well as those 3 departments. And I love this, picture of the Blaylock Taussig Thomas Pediatric and Congenital Heart Center photo. And then, of course, we've augmented our palliative care that's been mentioned. We've opened new outpatient sites at Green Spring, Rockledge, and Annapolis. Our trauma program is for pediatric patients is now run by our pediatric trauma experts. So lots of accomplishments in clinical care. More include an approved business plan for augmenting behavioral health. And you may have heard that we were successful in helping to recruit John Campo, who will be coming to lead the division of child psychiatry. And child psychiatry actually began at Hopkins with Leo Kanner back in early days when people didn't even talk about child psychiatry being a field. We have initiated population health initiatives. I think that there have been many, but particularly some with priority partners focusing on asthma, sickle cell disease, and maternal mental health with community health worker support, as well as some of our work in school health throughout the city and also in our rail center. We've had incredible provider commitment to excellent care, including, for instance, John Gearhart completed his 1,000th extra fee surgery. That's pretty incredible. And then great patient satisfaction scores. Pediatric surgery specialties are above the 50th percentile in every age category. And there are many other patient satisfaction stories that we could give regarding the excellence of the clinical care from the eyes of our patients. And finally, child advocacy. I think on the Johns Hopkins Medicine level, we have really worked to have the Children's Center representation and pediatric representation at all the important tables that are making decisions. In Maryland, I will say a few words about the Task Force on Maryland Maternal Child Health, which I think can make a big difference in this state, and then nationally and globally. So some of the areas where we have now pediatric representation include the Office of Johns Hopkins Physicians, where a lot of the decisions are made around strategy, clinical strategy in the region. The Office of Telemedicine, really excited to have Brian Hasselfeld lead that, who is MedPeds trained, as well as our own Helen Hughes. In the Education Office, we have great representation in the Dean's Office. We have a representative on the P&T committee, Dr. Cook, though I think we need more representation on the P&T committee, not just Dr. Cook, and gives Dr. Cook some support. The Credentials Committee, the Wellbeing Council, formulary management, and there's more. And this has been an area that we've really tried to focus on so that we can make sure that the needs of children are really being addressed. And then I think in health equity, nationally and internationally, lots of work on talking about racism in child and adolescent health, talking about the issues that our immigrant families face, and talking about how do we really address racism so we really can achieve health equity. So looking to the future, what do we really need to be looking at for the future? And I think our future is really bright, but we need to really work on some things to ensure that children and families get the best care and that we preserve our tripartite mission. I think we still need to work on governance. The fact that we are in many different departments and that we are not often seen as a children's hospital, I think is challenging. I always say we are not a service line, we are not a functional unit. We are multiple service lines in a children's hospital, and we need to function that way, and we need to be invested in that way. We need to continue to work on our pediatric strategy for clinical care. We are situated geographically where there is a lot of competition in the area, and we need to make sure that we work on our strategy to make sure that we maintain our market share and expand our market share so that kids can get the care that they need. We've talked in the past about branding. Some people are still confused by what a Johns Hopkins Children's Center is. And we are a children's hospital, and that is also in many other different locations providing the whole continuum of care. So how do we make sure that we brand ourselves appropriately and market our worth appropriately? And finally, we need to continue innovation in our missions. And I think we are in an interesting time now with COVID and with social unrest. How do we really respond? And we are not going to be the same. This is just a slide talking about how, in the beginning of COVID, we were just at that stage of resolve, trying to address the immediate challenges. We've moved to resilience, so addressing the near-term challenges and the broader issues during the shutdowns. And the impacts are related to the impacts that we talked about in a slide that Maggie showed earlier, really talking about, these are now the mental health impact of COVID, the economic impact of COVID. We've worked on return, on creating a plan to return back to scale. We're not totally at scale yet, but we're getting there. But I think we also need to reimagine and reform, because the healthcare delivery system is not going to be the same moving forward. I think that there's some good things and some not good things about how healthcare is changing. But we need to be really part of that discussion on transforming healthcare to make sure that we provide the best care for kids and families. Part of that is continuing to advocate for kids, that kids don't get lost in the fact that a lot of people feel like, kids are okay during the COVID pandemic. And I think we all know that kids have been affected deeply and families have been affected deeply by this pandemic. Looking to the future for the state, the task force on Maryland maternal child health was something that I felt really strongly about, that we needed to really have attention in the state on maternal child health, that we have a Medicare waiver and an all-payer system, which I think has inadvertently focused on very much on expensive adults and less on the maternal child health population. And so that's why I wrote legislation to get a task force formed, and the recommendations just came out in the last month, and we are working on the action plan on how to get some of these recommendations implemented. Some of them include that maternal child health must be one of the state's 3 population health priorities. Right now, the priorities for CMS on the state are diabetes and behavioral health, 2 very important areas, but they have focused almost exclusively on adults, and not on what are the early antecedents to diabetes, for instance. So having maternal child health becoming one of the state's 3 population health priorities, I think would be of great help to have it be on the radar. Second, have metrics in Maryland's all-payer system that go beyond Medicare. It's a Medicare waiver, so the metrics are Medicare, to include Medicaid and to include the maternal child health population. As we all know, maternal child health is not covered except for a very small percentage of children by Medicare. Third, that there be a standing state maternal child health committee formed to develop a blueprint for maternal child health in Maryland and tasked with monitoring outcomes and implementing interventions. In this state, there is not a council that's focused on maternal child health. There is a branch of maternal child health in the state, but they focus more on specific programs that they must administer. There used to be a governor's cabinet for children that was recently disbanded, and how do we make sure that there is a group that is constantly keeping their eye on outcomes for maternal child health? And finally, that hospitals must report child outcomes and investment in child health programs, not just Medicare, and that HSCRC, our rate setting commission, must consider carving out children if we are not able to really address the needs of children, the maternal child health population in the state. So I think that there is some momentum around this in the state now. We are meeting with Bill Ferguson, who was the initial sponsor of this legislation, as well as people in the Maryland Department of Health, to really address some of these issues to make sure that maternal child health is really addressed in the state. I always show this a slide, which I think is how we need to think about, and we probably all here do think about maternal child health, but a life course view of health risk, that we want to keep everybody on that low risk trajectory across the life course. That we know that children's brains and bodies are more plastic early in life, and that decreases over time, and that there's detrimental effects of lifestyle challenges and increasing mismatch as we all age. That adults screening may be too late to reduce risk, and right now we operate more on the steep part of these curves, and that for effective adults, interventions have limited effect, and that if we really want to improve health for the population, we need to be looking at mothers and infants as effective points to intervene, and we have growing research showing that there are biomarkers of risk, and children and adolescents as effective points to intervene. I think a lot of the economists also agree that if you want to really save money overall, you need to invest early. And we also know that the science shows us that what happens early, it's not just what happens early in life affects child health and adult health, but also intergenerational health, and that there are heritable, genetic, epigenetic, environmental factors that affect risk of ill health in the next generation, and that we really need to also focus on the human reproductive cycle and making sure that we are not generating an intergenerational cycle of disadvantage. So I think this all points to the fact that we need to continue to be advocates to make sure that we are focusing and investing early in the life course. And Frederick Douglass said that it's easier to build strong children than to repair broken men. And I think that that's what our work is about. Looking to the future, the driving force is really our mission, our vision, that Johns Hopkins Pediatrics is the birthplace of modern pediatrics and the future of health. And I'm really deeply indebted to all of you for allowing me to be the pediatrician in chief and director of pediatrics in this hallowed place. I've learned from all of you and know that this place will continue in its strong tradition. I'm gratified that you're going to be in good hands with Maggie and David leading the way. COVID has brought out the best of Hopkins, and we all have been changed by it, but there's no doubt that we'll all get through this, and I think we're going to be better for it. So in my last words are really, to never stop fighting for kids. I always say that children are 10% of healthcare spending, and they're 100% of our future. It's the right thing to do, and I will be continuing this fight just in another location, and are happy that we're all in this together. I believe investment in children, adolescents, and families is more important now than ever, and I'm really grateful to having had the chance to work with all of you, and we'll miss you and Johns Hopkins, but hope that we can continue in this ultimate goal to make sure that children, adolescents, and families are healthy. So thanks.
Thank you, Tina. It's, I know I speak for everyone when we wish we could just come up to the podium and hug you. We're doing that emotionally, certainly. Your impact on each of us will be long lasting. And on me personally, it's just been a huge honor to work alongside you. I've learned so much about kids and your passion as you described it and laid out the case for kids at every opportunity is unmatched. And I also believe you are now an honorary pediatric surgeon. So I will present you with a call schedule as an honorary gift so that you can continue your work here. You'll be greatly missed. We love you and we miss you so much.
Tina, you can see all the chats coming in. I think that that's our virtual standing ovation and team thanks for the work that you've done and the leadership that you offered and the vision that you've shared with us. I think we will all be the better for working with you, and we will continue to learn from you as we go forward. Just in the last couple of minutes, I wanted to show people how we're thinking about the Children's Center going forward. And Tina, could you back up one, please? So the Hopkins Medicine always has these strategic plans, and these are the things that we're all supposed to be thinking about. And I just wanted to give you a very brief insight as to what we're saying to the hospital, to the School of Medicine, to the dean, that how we are looking at this for the Children's Center. We don't have time to really make much of this, but I wanted to show you how we're setting it out And I want to invite everybody to participate in this conversation and work with me going forward to make sure that our objectives, our goals for the next several years are actually put into place. So Tina, please go next to the next one. So we're supposed to be making it easier to be at Hopkins, and for us, it's care coordination, it's patient and family engagement. We've really had a difficult time with some of this stuff. The ones in red are the ones we think are the sort of the most critical. Patient access has been a huge issue, and we're working carefully on it, working with our Patient and Family Advisory Council to improve patient and family-centered care. Keep going. Tina, next one. Great. So well-being, so we talked about making it easy. The next one is well-being of the people in the community. Again, we're really thinking about our community engagement and access to, not just access to care, but really the population health focus. We talked a little bit about diversity, and I really appreciate the leadership from Maria Leva-Hemker about our diversity work and our Children's Center Diversity Council, which is a pretty incredible group. We have a lot of work to do to make sure that the Children's Center as a community is expresses our intent for diversity and inclusion. So I think that's a huge focus for us. As Tina mentioned, integrated behavioral health is something that our community really needs, our patients really need, so that's going to be a big focus. Next. I like that Tina mentioned that we have a bunch of new faculty who are representing the Children's Center and the Department of Pediatrics on hospital committees and system-wide committees. We need to keep doing that. We work as a standalone children's hospital. We feel that way sometimes, but we have to stay integrated to the rest of the hospital, or the Children's Center voice will not be heard. So I will continue to push people to participate in system and hospital committees and keep the voice of pediatrics at the forefront. Please keep going. Pushing the boundaries of science and education. It's our history, and it's got to be our future as well. We are working on ways to strengthen the pipeline of pediatric clinicians and pediatric researchers. I think using the clinical excellence track will help us in some way to bring really the expert pediatric clinicians to Hopkins to lead the way in terms of creativity in pediatric medicine. The life course precision medicine cohorts. I mean, I think the precision medicine is really something that we believe in Children's Center. It's hard to get enough attention for the Centers of Excellence for Pediatrics, but we've got a couple, we've got to keep going. We've talked a lot about educational tracks, and I think one of the challenges is that we don't have great models for successful clinical education in the setting of distancing. Nicole and her team have done a great job. Eric Biondi with hospital medicine, we're really trying hard to make this work. We have so ways to go. Next one. Once we're worried about the pipeline, we also need to sustain. So I think optimizing the support for especially young investigators with K Club, Science Fridays, making sure that people understand the resource that is the B Corps and use it effectively, getting better about research collaborations with our children's hospital, making that easier. And as soon as the new research space building starts again, we'll get our planning going for that. All of these things I need everybody's help with in the next year or two just to make sure that we are together. I think we've talked about this one already. Let's keep going. So the quality and affordability, I think we have had a lot of focus on safety and quality in the last 2 years, and we need to keep pushing that and make sure that it's through the whole system. We really need to enhance our community and our culture around quality and safety, and make it all the way across the infrastructure of Hopkins Pediatrics, not just in this hospital, but across our whole system. We have done a lot of work on strategic planning, and the clinical services roadmap is something we need to really push. We are working with the dean and with Kevin Sowers to really make sure that they understand our needs and our strategies going forward. And I think that's gaining us some traction. Next one. We have worried a lot about CLABSI, and not just because it affects our U.S. News and World Report rankings, but because it really matters to our pediatric patients and to us. So I appreciate the work being done on the CLABSI protocols. Mortality review is something that we've been pretty successful with, and I think it's helping us to understand our own systems. I appreciate the work being done. New things with Sean Ralston's leadership, we got engaged in the Solutions for Patient Safety. Emily Boss's leadership, the children's surgical verification work, and the NISQIP work. It's really making a difference in the way that we are thinking about quality and safety, and we have to push push the boundaries of quality and safety. Next. Working like one organization, that's always a challenge for an organization like Hopkins. But as Tina mentioned, the governance structure, I think that's probably one of our biggest tasks in the next 2 years, is to make sure that we can recreate a governance structure and insist sort of on a governance structure from the system that reflects the complexities of the Children's Center. We really need people to understand how we work in the Children's Center and develop a governance structure with a hospital that reflects that. And next. We can keep going. Next one. Actually, let's go ahead and go to the end, so we have a couple minutes for questions. So this is the Johns Hopkins letter, just a reminder, from 1873. And I think B and C, well, A, B, and C, really, that's really what we are focused on. That's who we are in the Children's Center. We want to provide care and mostly care for children who need us. We want to provide care without regard to sex, age, or color in this institution, in this city. And we want to make sure that we are providers of the highest character and greatest skill. I have faith in that. I still think it's important for us. It resonates with all of us. And we need to move forward on those goals. Next. And finally, I just want to say thank you. I admire you all so much. And I really think we do have a good future. We have some interesting challenges coming up. But I think we're starting with a powerful sense of community, and the intelligence and generosity that I feel from all of you really leads the way. So thank you.